Welcome, everyone. My name is Jane McKay. Many of you know me. I'm a general internist and I work with Dr. Rick for more years than we care to comment. And today I want to talk to you about long COVID, and I'm doing an update. And a lot of it is actually based on the second annual Canadian Symposium uh, on long COVID that was in Edmonton in the last couple of weeks, actually. So it's a different style, and it's based on my lived experience of those with lived experience. So with that in mind, let's get going. I'm on Bowen Island, by the way, and Squamish territory, saying thank you for the opportunity to live here. So let's I'm going to try to advance my slides here. So again, we're going to talk about some highlights. And what I learned very quickly is prevention is an important part of what we need to talk about. So we'll be spending time on prevention. I've selected some studies that I thought were very helpful and quite prudent to discuss. I have reviewed about 20 hours of educational material on a long COVID webinar, and I've selected studies, and I've gone into the recover information in the state. So I hope to get through all of that in this time frame. So anyone with or without long COVID needs to remain amazingly, incredibly diligent in preventing another infection with SARS-CoV-2 Omicron variants. We're in the world of Omicron only, okay? All the lineage is Omicron. It's highly transmissible. It's aerosolized spread. You got a mask, and you have to talk about ventilation. I learned a lot about this from my fellow participants with lived experience. So just so you know, between April and August of 2022, 98% of Canadians had antibodies to COVID, surprise, surprise, and 54% had previous antibodies from other infections. Well, now it's Omicron, and asymptomatic carriage is extremely prevalent. So everybody can get it. So I want to just talk a little bit about how Omicron has changed everything. It's incredibly immunoevasive, meaning your immune cells can't figure out what to do, and it has a very high risk of infection. So I just want you to reflect on the fact that influenza worldwide every year causes 1 billion infections worldwide. COVID now causes 3 billion infections worldwide because of changes in reproduction rate. And the variants change every 3 months, and there's no seasonality. I'm not trying to scare you. I'm just trying to say we got to protect ourselves. A mild SARS-CoV infection can cause health effects 3 years later. This is a great study, but it's beyond what I can present today. Maybe we'll come back to it in another day. It talks a little bit about how COVID keeps living, how the SARS-CoV-2 virus modifies and may become some aspects of it may become chronic, just like we see EBV chronicity causing things in other illnesses like multiple sclerosis. So we're not sure yet, but there's concern. So how are we going to know how much COVID's in our neighborhood? Well, it's politicized now, so we don't have a dashboard. So there are wonderful individuals that are taking this on. I'm going to introduce you to the COVID-19 Resources Canada website. And I'm going to talk to you a little bit here about wastewater data. I didn't put a slide in, but wastewater data is an indication of a population's health. And actually, this is one thing the BC CDC has quite a bit of resources on. So if you go to the BC CDC and look up wastewater, and also look up respiratory viruses. You actually may find data for in your neighborhood of where you're living and the actual infectious rate or amount, because remember that there's a lot of asymptomatic carriage. So actually sometimes the wastewater could be a more better indication. Now, before I go on, I just want to highlight this website. This is an older picture, but I just took a screenshot so you know this is the dashboard. This is the self-made dashboard by this Toronto physician infectious disease and many volunteers that will give you an idea of the severity. I'll leave it to you to go to find that. So I want to talk to you about, all of you know about masks, but this is what I want you to talk to your family and friends about. This is an example of what it is like to breathe. And this is a breath. This is a breath right here. This is someone breathing. This is a lab, and this is how far that breath goes. Here's another human being in a mummy case, so to speak. So it's, you breathe, that particle size that goes out is pretty significant. Now, what happens is that when you're in a closed space, those aerosols still stay there, right? So these little dots are those aerosols that are swimming around in the air around us. And some of them fall, the big ones fall to the floor, but the small ones don't, they stay around. So again, a lot of this you may or may not know about, but it's more educational to help others understand the importance of things like ventilation. So ventilation, you lots of different things. Open a window, so it's winter, open a window. Get the ventilation going, put fans on. I have my fan on. When you're in an airplane, turn on the fan. So ventilation is incredibly important. So this is something that I think all of us should know about, that CO2 monitors are a proxy for air quality. We breathe out CO2. So if you can afford a decent CO2 monitor, that will help you determine the air quality of where you're going, so you know what your risks are and you can make an informed decision. Because a lot of everything we do nowadays is about making informed decisions. And so a CO2 monitor will tell you where you are in the good zone, the green zone, or the red zone, as I call it. So the green zone is a parts per million CO2 count less than 500. I'll come to it on the next slide. And the poor zone is higher, 1,000 to 1,500. So that will help you have a better idea of air quality. And when you look, there's multiple meters that are available. The markers of expired air is really a marker of potential virus. The higher the CO2 ppm, the poorer the air quality. As I said, good and poor. It's a marker. It's something you can have with you, but it doesn't change. You need to mask, okay? And we're coming to masking. Air purifiers. So air purifiers are some things that we can add to our lives to help us decrease the risk and filter out those viruses. They don't filter out CO2. So this is where you can't use your CO2 monitor if there's HEPA filtering happening. And there's lots of DIY models that are available. And I didn't know this. I found all these things out in the last couple of weeks. They take out the virus and smoke, but not the CO2. So the building specs are really difficult. And the one reason that the conference was held in the location that it was because there was access to air quality data. So just if you ever need to know, Edmonton Avario has air quality data. So that is kudos to the organizers of the conference. Don't forget about masking. So this is an old study, but the bottom line really is wear an N95, okay? N95. These surgical masks are used in the hospital. Me, as my practice of pattern of practice as a physician seeing patients in acute care, people are coming in with something else but have COVID. So become sort of a passive agent in the context of an admission for another reason. So I wear N95s everywhere, in the hospital, but in my office, I may wear a surgical mask because it's important, right? And don't be afraid to ask your healthcare provider to mask up, okay? Um, don't forget about fit testing. Everyone wonders, well, what's a fit test? It's basically you trying to say you put a mask on and you see if your seal's good. It's trying to see if around your face you're exhaling or inhaling air. And if it's not fitting, it's not working. So that's why a fit test is useful. As healthcare professionals, we do one every year. And for those that are not healthcare professionals, in the Vancouver area, it's the first aid, Vancouver First Aid, $30. So pretty decent investment. And then if you're in other areas, just Google fit testing. Don't go to a place that charges you a lot of money. This isn't a very expensive test, but an important test, okay? And really, if your weight changes or anything like that, you have to have a second fit test that year, okay? So there's lots of preventative information that's available. This is one site, but this is the BC site, but there's other sites as well. But I think if you can do all of that, you've done everything. And that's great. And I know it's important. So vaccination, let's not forget the vaccination is important. In the beginning, those vaccines were 100% effective. They're not anymore. But they're still helpful. The flu vaccine isn't 100% either, but we still do it. It decreases the amount. So please keep vaccinating. Don't forget about Paxlovid and COVID. There was a study that an article that I read that said we're not using it enough. So Paxlovid will decrease hospitalization. But now in the era of Omicron, what you want to do is decrease the risk of actual severity and hopefully chronicity. And there is evidence that chronicity will be decreased as well. So, but in the acute case, it helps decrease the intensity of the infection. There's still a risk of rebound, meaning the virus particles acting with your body again after the Paxlovid is gone. But I'll talk to you about longer use Paxlovid in a bit, okay? Now, I want to just go over the mechanisms. I'm not going to spend a lot of time on mechanisms this time. I've done it before, other updates. Viral persistence means that some individuals cannot clear this virus, and you will have viral particles that lead to chronic inflammatory response. These two are linked. And then you can have microbiome dysbiosis. I'm going to talk about this one. Endothelial inflammatory responses. I have talked about this in the past. I won't be going into a lot of that right now. Neuronal inflammation I will touch on, and mitochondrial dysfunction I will touch on as well. So just as a precursor, 6 different mechanisms here. Remember, when you have 6 different things happening or more, it's pretty tough to get one medication to cover all these things. So that's just a precursor for questions about information that I know that people will be wanting to ask on. But remember, we have 6 mechanisms we're trying to treat. So gut dysbiosis and the brain. I want to go over this because this is really important. So here's the healthy side. So here we have these very happy bacteria that live in our bodies, and they're in certain ratios, and they work together with the intestinal lining, and it's a happy microbiome. We're colonized with this almost days after we're born, and it's different in different areas. But I want to just show you some things that are really important. These little bits here, these sorry about that. Oh, even worse. Okay, so these cell locks right here, those cell locks keep those cells together. So there's no leaking, none whatsoever. But if you look at the unhealthy side, you see that the microbiome are different. They seemingly are not as healthy. And the SARS virus is stuck here on some of the receptors. And we've got leaking happening here. We've got leaking of bits of microbiomes. We've got leaking of parts of cells. And this leaky gut syndrome causes systemic inflammatory response. And in part, because this is happening at the with the gut microbiome axis. Sorry, my pods are falling out here. The gut microbiome axis. So I wanted to just kind of go over that in a little bit more detail. And again, if you look at this slide here, this is a slide of the neurocognitive impacts of long COVID. And I'm not going to go into all of it at this particular time, but I do want to talk to you a little bit about gut dysbiosis and impaired intestinal absorption. There's alterations in tryptophan, resulting in lower serotonin and induced dysfunction in the vagal signaling. The brain cells seem to be part of the blood cells are part of it. And there's a lot of cytokine changing and glial cell activation. A lot of this is due to the leaky gut sort of phenomenon. They have what they call exomes, or little packages that go from the gut to the brain. So lots happening in that axis. So I want to talk to you about an unpublished study that was presented, and it was one of the publishes that one of the studies that was then on a webinar just 2 days ago. This is a Dr. Liana Falcone lab. She did a study of 21 cases of long COVID participants, up to 24 months of long COVID, quite severe. And she noted when they did studies of the biome that there was changes in microbiotica, showing an increase in autoantibodies as well. But the question is, what does this actually mean, and how does this cause illness? So, again, what she saw was stool samples of severe COVID had decreased microbiome biodiversity, and there was neurologic changes, and quote unquote leaky gut was proposed. So she also found what's called blood zonulin. Zonulin is a marker of a leaky gut, and bacterial markers were also found in the bloods of people with long COVID. And there's alteration in the B cells. So B cells are part of our immune system, and the B cells, they're mantle B cells. So you don't have to worry about the name per se, but they're changed, and they were changed, and they changed the immunoglobulin production. So immunoglobulins are the protein antibodies that our body produces that are important for disease regulation within our body. So what does this might mean for us? Well, she took this stool from the samples of the long COVID individuals, and she gave it to mice that were pure mice. And so what happened is she saw translocation or movement of bacterial parts into the mice bloodstream. Immune changes were seen in the immune markers, in the immune nodes of the mice. The mice behavior became very different and suggesting a CNS alteration. And when she took microscopic pictures of the gut, she found the gut lining was leaky. So basically what she's done and reproduced in a mice model exactly what happens in long COVID. So, and what did she also see, which is incredibly important, is activation of microglia. And you probably hear us talking over and over about microglia, which are a part of our immune system in our brain. They're part of they're a advanced immune cell, And we always talk about microglia health when we talk about our drugs like low-dose naltrexone, low-dose Abilify in chronic fatigue syndrome. So just so you know, they're not working in long COVID either. And the astrocytes, which are the cells, the nervous cells in the brain, are activated as well, meaning they're working, they're sending out pro-inflammatory things, chemicals usually. So this is just the beginning, right? And this is just the beginning of what does this mean and how can we treat this? So this leads the way for therapeutic studies, and this is incredibly important because then this takes us to therapeutic models. And so what she did say when I listened to a webinar recently is that we don't really know yet if the probiotics that we recommend actually stick. In other words, do they graft onto our microbiome and feed the microbiome? Not sure yet. And so really, we're still at the stage where we have to actually identify the type of supplements that are best to restore our microbiome. So what do we do in the meantime? So as I've said in the past, low inflammatory diet, Mediterranean dash others, still try pre-probiotics, okay? Mixtures of dietary foods, trial different probiotics, and we're not sure if they're going to engraft, but hey, what the heck, give it a try if they're not too expensive. And Michelle St. Germain does a lot of talks for us, and she's a dietitian, has a great understanding of illness in the complex setting. So she will be doing, if you go to the special lecture tab on Dr. Arsenault's website, you'll see when she's speaking. So I want to talk about taurine because taurine is a chemical that's an aminosulfonic acid. It occurs naturally in our body and is present in foods such as meat, fish, and eggs. At a cellular level, taurine is involved in energy production, and where it could obviously be relevant is improving energy production. So things like long COVID and ME. So there's some claims been made that taurine supplements, and these aren't claims per se, there's studies actually that have been done in American Heart Journal on use of taurine in heart failure, diabetes, high blood pressure, and fatigue. So there's some evidence, there's some trials from other illnesses that it's helpful. They're not sure about the dose. So when I went to the good old Google to try to figure out how much taurine, it was 5,000 to 3,000 milligrams. So that's really where the taurine information is coming from. It's coming from other areas, but there's more. So there's more that we've talked about on taurine. It could be helpful. And I'm going to talk about this study that was done by this gentleman, Dr. Gavin Audet from Alberta, and that taurine metabolism is altered, taurine levels are lower, and gut ACE2 as the enzyme is completely absent in the gut. So I discussed about how it helps in other areas. It's low in long COVID. And so what are we going to do until this trial is done? This is a phase 2 trial, meaning beginning trial. So what are they saying with this trial? They're saying taurine supplementation may make a difference, but it's not ready for the main game yet. They don't have in other words, a randomized controlled trial. Doesn't mean you can't take taurine. And so what do you do? Well, you take taurine if it's going to help. So taurine is a biomarker, meaning it's a test. We can't do it as a clinical test, but some supplementation is potential therapy, 500 to 3,000 on the labels that I've seen. ACE2 is really important in COVID infections. In the gut, it's gone. So maybe ACE2 supplementation, there's some proprietary products being made for ACE2 supplementation along with taurine for long COVID. So this translational research, so this research that's done at the bench going into can then lead to therapeutic trials. And I think that's really important stuff. So next, I'm going to talk about phenotype. This one was the most exciting presentation I've seen in a long time. It's a combination, and I can't present the slides because they're not out. But I want to tell you about it. It's really using artificial intelligence from some very well-known companies that are actually starting to work with scientists. And so they're using their technology and their business model and science together. And so they phenotyped a number of phenotypes. And in addition to that, they've also gone ahead and found 50 drugs that they're going to start repurposing. But they got to do the study. But they say it's going to be done next year. And I guess what's happening is technology's meeting science, and wow, AI. So great. So 50 drugs is a lot of drugs that may make a difference. They already have FDA approval, meaning they don't have to go through all that. So keep tuned, hopefully by next year. So I want to talk to you about something that was controversial, and that's the CAN-PCC guidelines. So the Canadian guidelines for post-COVID condition, yet another name. So they were the naming issue was brought up and discussed. Why did they bring in yet another name for post-COVID instead of long COVID? It's post-COVID condition. So anyway, regardless of the name, there's this 6 pillars of scientific individuals, groups that have gotten together to produce a relatively decent guideline that I think is quite helpful. I mean, from my perspective, it's really things I know, but it's things that you may not know. So I think it's very helpful for you to have a look at. So they're evidence-based guidelines, meaning they did the best they could to find the best information. And the information is laid out in maps. So it's actually quite user-friendly. So this is what it looks like. And there's a list of good practice statements and recommendations. Rec maps is recommendation maps. So I'll leave you to navigate that website on your own. They have 12 good practice statements, 21 recommendations. It's good to have a look at. I mean, it's for those of us that are in the field, it's kind of things we know, but it may be for others that don't know. So good place to go to. And it's Canadian, homegrown. So this is what what I loved about this conference so much was the equality of those with lived experience and scientists. I can't say a better combination. To have the scientists together with those that are living with illness in the same room is so important. So here we have, this is a study, a poster session that was done, and it's living with long COVID, learning from lived experience to informed practice policy. And it's patients' stories, it's lived experience stories that were recorded and themed. So it's a way of doing qualitative research, a theme analysis it's called. And then from that, there was a number of recommendations and policies made. So this is the poster that acknowledges all those wonderful individuals that with the energy they had participated in this experience. And so again, lived experience online, they created together an online resource for knowledge dissemination. It's again, qualitative research, which is really quite good research and descriptive. And the themes identified went on to create topic pages that were important priorities for individuals that are living with the illness. So 6 major themes, 25 topics that are published. On the slide is the name of this person, Susan Law, who can help guide you in the right direction. These are the priority topic themes. On this side are the topics, and these are the themes. So, I mean, I'm not going to go through it all, but it's looking at things that are important to those with lived experience, talking to policymakers that can actually make a difference. So really, really good work. So how does post-COVID change over time? This is Angela Chung, heads up the the long COVID web. Dr. Arsenault and I vintage, and also knows Dr. Arsenault quite well. So their aim was really trying to figure out, well, how does this virus change over time? How does this change? Like, what happens? So what they found is there's so many different heterogeneity of symptoms and mechanisms. We just can't figure it out quite yet. They need to do the subgrouping, which subgrouping is a topic all over the place. What they were really looking for was biomarkers with long COVID that could help with more accurate diagnosis. Everybody's looking for lab tests that will help for treatment strategies. And they're also looking at, again, the immunologic, the same themes coming out over and over again. So what did they in this short study, they found that the three top features that they found in their cohort was the T8 cells. So cells of our immune system start from our progenitor cell, and then they mature and they become a B cell or a T cell, and they have different roles in the immune cell function, and then they have numbers associated with them, and those numbers determine the role. I mean, it's a complex system, but the T8 cells are down, which is part of more of our innate immunity. So sometimes called exhausted T cells, you'll hear that name as well. Spike protein is up, and people the age is an important factor as well. So those are the three things that they found were important in this cohort, so measurable, and we'll be following this cohort out over time. So this one, I really like this study because it's with a group of individuals that I've spent a lot of work with over the years, and I want you to just know that you can contact this individual. And this is about POTS, and it's native POTS, meaning those without COVID, and POTS with COVID. Are they different? And you know what? They are. So the most important demographic was the age. So those with long COVID are a different age. So you can see the difference, and the p-value, which means it's statistically significant or important. The changes that you can see in your heart rate and your blood pressure in long COVID, what we see is a lower heart rate and systolic blood pressure and diastolic blood pressure in relation to those that don't have COVID with POTS. And in long COVID POTS, when you stand up, you have a lower pressure, and that's both systolic and diastolic, and a higher heart rate. So the jump in the heart rate is higher, and there's changes in the tone of the parasympathetic. So the rest and digest nervous system, and the sympathetic, the active nervous system. So, I'm still trying to figure out long COVID POTS myself personally, because, it's a different beast in itself. It's not what does that mean for us? What does that mean sort of going forward? The slide doesn't want to go forward. Just a second. So it's different. I told you about these numbers. So what does it conclude? I talked really about the conclusion, really just to reemphasize they're different. The heart rate and blood pressures are different, and maybe they have a different pathophysiology. Maybe the way it's happening is different. But what do we do about it? That's the most important question for me, is how am I going to help you? So I wanted to say this was a small study, but still an important study. So when I'm looking at long COVID POTS, and I saw someone yesterday, the heart rate will be higher. So I'm looking at trying to use ivabradine, has less of an effect on blood pressure. I'm going to be looking towards salt and water, knowing that the blood pressure changes are going to be lower, that there's going to be much more salt water compression stocking recommendation already, which I already do. And then I'm going to mitigation, right? So that's a vasoconstrictor. So that squeezes up those blood vessels. So This is one of the ways that I'm looking at starting to treat long COVID POTS, basically from what I'm hearing from the literature and this study that was done. So we'll see. And I'm gonna, because this is an aside, but sometimes there can be these spikes in blood pressure that happen too, that I'm still trying to figure out with Dr. Raj in Edmonton, so or Calgary. So we're not sure yet. So some of you that are going to that are my patients that have this will be getting serial ABPMs, because I need to know what to do about the blood pressure going up and down. Is it a response to the low blood pressure? Your blood pressure goes high, your heart rate goes high. Anyway, I don't want to digress too much, but it's different is basically the bottom line, and the treatment will be different. So I want to introduce this person. Dr. Funmi Okunaola has started this website called Long COVID and the Answer. She's a family doctor, and she's so committed. And she's got lots of individuals that are advisors, and lots of podcasts on her website, and lots of Ask the Expert options. So just have a look at that. One of the many good websites. I want to talk to you about this website, Long COVID Web. You know, if you have the energy and you want to do something that you think that will be helpful, look at the research tab and look and see if there's an opportunity for shared experience for working or helping in the patient partner network. Those with lived experience, incredibly helpful. And the stories are what motivate scientists even more. So just a plug to if you have that extra ounce of energy to become involved. So I'm going to switch gears a little bit and go to some trials now. So this is just published. Does antiviral therapy for long COVID make a difference? So this study was done by a guy named Hector Bonillo, who you don't know, I know quite well from my MECFS work in the past. Anyway, he's the primary author on this study. So the bottom line was the average time that individuals had long COVID in the study was 17 months. They trialed 15 days of Paxlovid, and the conclusions and relevance, it was safe, but it didn't make a difference. But what they said is more information is needed, and you'll see some more studies coming along. So this answers does longer Paxlovid for 15 days make a difference? Well, not that we can see, but that's not the end of the story. So I want to introduce you to Recover. The Recover is the NIH funded trial center in the States, which is a driver for many of the work that will happen elsewhere. And I wanted to I'm just going to whip through the trials that they're going to, well, I don't have to whip through about, it's 4:10, so I'll go slow. So I'm not going to give you the backstory. There's lots and lots of information on Recover and how they got from data collection to study was a big experience in itself. I'm just giving you the end product, okay? So let's talk about Vital. Recover Vital. Vital is viral persistence and reactivation and immune system deregulation. It's a 25-day trial of different combinations of antivirals. Again, we're looking at the viral persistence issue. Now, if you could, and they're following for 4 months, and that they are enrolling, they're already enrolling, they're hoping to finish in March. So rapid turnover, really rapid. So I mean, it's going to answer questions about whether 25 days of antivirals will make a difference. So, we're just in the beginning, and we've already gone from none downward to up to 25 days. So seeing if that persistent amount of antiviral will help our immune system clear a little bit more effectively. So this is Recover Neuro. They think this might be done in 2025, and it's got sorry, this isn't sorry, I take that back. This isn't meant to be in this slide. my mistake. That was my error. Whoops. Sorry about that. So just please forget about this part. I'm sorry. So it's looking at two different it's looking at using Brain HQ. So Brain HQ is an interactive brain study program that's been already built, and it's really working on your brain. And the intervention arm is using Brain HQ, and sorry, I made a mess of this slide and I really apologize. So, so, what this recover neuro, please don't pay attention to this, and I apologize for the error, is using neuroplasticity to see if they can improve the cognitive aspects of long COVID. So, next slide will be, that's the Brain HQ trial. Okay, sorry, I made a mess of the slides. I missed that on the review. So I want to talk about the autonomic clinical trial. So this is two groups, and it's a really kind of an interesting study because they're looking at IVIG in POTS and long COVID. And so the hypothesis here in this trial is that the immune dysregulation is part of why long COVID POTS is occurring. So you're not aware, but many diseases that have autoimmune features, we will use things like IVIG. So I'll give you an example. So there's a condition called ITP, or immune thrombocytic ITP, really too many low platelets from immune dysfunction. We give them tons of IVIG, it gloms up all the receptors, and then the problem goes away. So it's the same kind of concept. Give lots of IVIG and see if that can overwhelm and outmaneuver the immune dysregulation that occurs with long COVID POTS, right? So now it's a 9-month trial, so 1 week every 9 months. It's a fair chunk of IVIG, really. And they're looking at heart rate, dizziness, and fatigue. And they're going to be doing monitoring, lab tests, fitness trackers, and surveys. And the second part is the ivabradine. Remember, we talked about the heart rate change. So ivabradine versus placebo. So that's the Recover Autonomic Clinical Trial. Now, oops, I'm going backwards. The Energize trial. Okay, so this is 2 trials, actually. They're looking at exercise intolerance and post-exertional malaise. So as primary, more relevant symptoms. So what they're going to be doing is cardiopulmonary rehabilitation, design, and I'll explain in a moment. And the PEM study is structured pacing. Okay. So so that's the Recover Energize trial. So that should be done. All of these are meant to be done by early 2025. So it'll be really interesting to see where this sort of pans out over time. Okay, so that's the Energize trial coming. I want to talk to you. Oops, I'm having a hard time on slides. So this is the Recover Sleep trial. This is the last of the 5 trials from Recover, and 1,000 enrolled patients, 2 interventions, and 474 participants, hypersomnia. 1 drug we use already, modafinil, another solriamfetol, and they're looking at sleep time. And then there's another study looking at melatonin and light therapy, and they're looking at quality of sleep and sleep initiation maintenance. Now, I apologize, I did take sort of the brochure aspects of this study out of my talk, mainly because I thought I wouldn't get this far. So, and I did. So I can add them to a slide deck that can be available. So reflections. So this is reflections, that I think all of us want to know more about. We all recognize, I think, all of us, that the care of people with long COVID is sometimes suboptimal. And there's gaslighting, there's lack of access, there's, you name it, it's not good. We know that prevention strategies have been utilized, maybe not so much by those that have long COVID, but certainly by those that don't have it. I find this a bit of a harsh statement, but a truthful statement. We have no evidence-based treatment. And so I want to take a pause here, because I want to talk to you about why Dr. Arsenault and myself use so many different medications for long COVID. We're doing that because we're translating information that we have from MECFS, where we've worked for many, many years, where there's lots of trials already, and we're bringing that over into the long COVID world. So, and then some of you say, well, why am I getting the diagnosis of MECFS when I have long COVID? Well, you can have both, right? So I think you need to realize, and that's why I want to just spend that moment trying to explain to you that the diagnosis of MECFS isn't meant to be anything more than a help. And the help is we have treatment. So the no treatment means we have no evidence-based treatment for long COVID, but boy, oh boy, do we have a lot of options for MECFS with lots of trials. Every drug we use has a trial. So there's no consensus on the terms. And this is what, and I try not to attach too much emotion to this, but remember, this is 4 years, right? So 4 years with a nascent, meaning brand new baby disease, it takes a little while for the world to get its head around what should we be calling it. So leaders in the world were the lived experience. They called it long COVID. So, many of us think, well, why don't we just call it long COVID and just change the words around a little bit? But, we have all these, we've got PASC, we've got PCC. And so I hope it gets simpler. Sure would make it a lot easier for all of us. So we don't have the appropriate healthcare systems in place to actually measure the burden of infectious associated chronic illness. We know from many, many illnesses in the past, you can get things like multiple sclerosis, you can get cardiovascular disease, you can have cancers. So we know that from other illnesses, but we don't have that infrastructure yet to really say, hey, how are we going to measure this? How are we going to monitor this for 20 years? How are we going to say HIV 10 years later, 20 years later, 30 years later, 40 years later? What is it causing, right? What about EBV? We know about EBV, we know about HH6, we know about others. So we don't have that scaffolding, and I'm hoping somebody smarter than me, can make the scaffolding happen. So long-term risk isn't known. Unfortunately, and all of us know this, there's politicization of public health by government. And there's misinformation, there's disinformation, there's anti-science, there's anti-vaccine, there's all kinds of things out there. And what the long COVID web is really committed to is to trying to get away from that misinformation, that politicization, and just try to sift through the chaff of or sift, my dad would say chaff, but sift through and find the best information available. Okay, so we're now to questions, and I'm earlier than I anticipated. So if that's okay, I have, I'd say 4:21, I'll start a bit early, and I'm going to start with questions. So you've dutifully put questions in the chat. So what I do is I look at them, I summarize them, I read the question out and try to provide you with an answer if I can. And sometimes I'll just say if I can't, and we'll try for next one. Okay. So, first question, my son is tested positive for COVID. Is Paxlovid appropriate for me? Short answer, yes. If you have COVID, yes, have a prescription on file. Can it interact with other health conditions? Potentially. Can it interact with other medications? Yes. All of that's looked at before it's prescribed. Now, disability. This is someone is asking about disability and being denied. So, and how difficult it is, and exhausting and waiting. Just, I think collectively everyone understands, and I wish it was a different experience for you, and try to know that we do our best, and we try, and I just do, I'm sorry. Is there a drug called atogepant for long COVID headache migraines? So actually, this is a atobagent is a type of migraine medication. It's not specifically for long COVID migraines. So typically what happens with migraines long COVID is they get worse. Now, can you use different therapies? Absolutely. And migraine or neurologists are probably the ones that are best to prescribe it. These drugs are expensive. Sometimes you can get special authority for them. But these can be game changing for people with migraines. So just that's something that's available. So will the slides be available? I'll talk to Bruno about that, about putting them in the Dropbox. I might clean them up a little bit and add a couple more. So let's see what's that, because it's nice to have them for notes and things like that. So I'll ask. So a question has come about pseudodoxidine angioflux as blood thrombotic therapy for fibrin microclotting. Thoughts now using nattokinase and serrapeptase. So a lot of this goes back to something I talked about on my last COVID webinar, is pseudodoxinase, all these agents are really agents to help alter a portion of the microclotting mechanism, which is actually quite complicated. And I don't want to go over the whole pathophysiology. So what I always say to anyone, and I know about these therapies, and but I don't usually typically prescribe them. I say to any individual looking for something that's different, is what is the cost, what is the risk, and what is the benefit? And can you get someone to prescribe it? So that's the concepts behind that. And they have been that's been available in the literature for a while, especially serrapeptidase. So it is something that is known and has been talked about. So the answer is it will be in Vancouver next year, is the next response to the pseudodoxidine question. Are you able to attend the Long COVID Barcelona conference next month? Yes, I am actually going to that conference, but I'm not going to Barcelona for 2 days. So I've signed up for the virtual conference, and I'm going to do another COVID update in December. I'm going to try to take what I can learn. I've already looked at the program. Doesn't seem a whole too exciting, but I'll try to make something out of it, and then maybe I can add some other stuff in there. But yeah, I am going virtually. I'm gonna have to set an alarm. Are the guidelines that we should be getting the latest vaccination still if we haven't had any adverse reactions with other ones? So yes, you should be vaccinated. You should be vaccinated, and you should still be getting the registration information just from, especially with regards to vaccination for COVID. Yes, I always usually say influenza. I always do influenza. You have to pay for RSV if you want to go that route. Next question. Curious to know whether conference participants were required to mask. Well, very good question. Yes, every one of us masked. The only difficulty we found, yes, we were all asked to mask. It was part of the conference, and totally respect it. There was a little bit of difficulty for presenters to speak clearly with masks. So although I know it did cause a little bit of difficulty when the speakers didn't wear their masks, but it was partly just to be able to be heard. So the masking was pretty universal. Slides again, yes, we'll do what we can. So here's a question. Spike protein of the virus combined with a blood protein fibrin setting off a chain of blood clots, resulting in chronic inflammation and brain damage. What does this mean for the vaccine? And if so, what vaccine should we take or not? So this is actually a separate question. So yes, indeed, there's many different mechanisms for inflammation on the vascular level and at the CNS level. And inflammation is definitely, and immune dysregulation is definitely part of it. So that doesn't mean you're not at risk for COVID. So the reason you do a vaccine is not for what happened in the past, but what will happen in the future. Because I've had about 5 people in my last group medical visit talk to me about having a COVID infection and not even knowing anyone that had COVID. So yes, please vaccinate. What vaccine? Well, unfortunately, the protein vaccine that was available is no longer available. So you're kind of at the mercy of I think 4 vaccines that are available right now. I hadn't checked into what's available close in the States, but that might be an option for some. So yes, please vaccinate is the short answer. How high is the asymptomatic level of spread? So this is an impossible question to answer because we don't have testing of asymptomatic individuals. So all you can do is go to the wastewater. Remember, I talked about wastewater as a marker of health, and look at the changes. And they actually break it down into the variants as well. So they break it down into K9, whatever Omicron variant it is. So you can go to the wastewater in your region to see the actual amount. And that's really a marker of asymptomatic illness, spread, basically, because they're not testing for asymptomatic spread. Next question. North Van Library loans out CO2 monitors. Isn't that great? I borrowed one for a quick check at home. Isn't that fantastic? Maybe other libraries are doing the same thing. I thought there were studies showing planes, fans circulated more germs. Well, who knows? I don't know every study, and maybe that's the case. I mean, what I've been told is open the air vent, let the air go down and out, wear your N95. If you're going to eat, take off your N95, put a new N95 on. And remember, it's an aerosolized spread. So, it doesn't hurt to do hand washing and sanitizing, just in case there might be a fomite or a virus particle settling. But that's the best information that I have. You may have more. Please share if you do. Whoop. So Dr. Al-Ali's 2004 paper, Ongoing Impacts 3 years after mild infection. I believe it looked at unvaccinated only prior to availability. That's a very interesting point that I would have to look up. I've tried to read that paper. It's a very energy dense paper. So are the long-term impacts the same for those who have been vaccinated? For those of us who have only one infection versus 5, 6, 7, 9. So I'd have to go back to the paper you're referring to. I know which one it is to actually find out. It was comparing hospitalized and non-hospitalized, but I didn't look into the vaccination status of all the patients. And so what vaccines do is help with prevention of illness. So if you've had one vaccination, your antibody wane is decreased. So I usually say, if you've only had one vaccination, you need to work to get your vaccinations up, because the vaccine antibody production is not like guaranteed forever. So it's a short period of time. And that's why repeated vaccination is being recommended. So I hope that answers the question that you're asking. Is there a difference in quality of N95 masks? Well, it's a good question. To get the designation of N95, it means something like that. That's a designation that you can only have. So there's different styles. There's the K and the N. Some people like the ones that have the broader bill, like the duck bill. But as long as they pass the fit test, they're pretty good. Now I have seen the term N100, but I haven't seen that clinically available in the hospital settings that I am aware of. How long do N95 masks last? So I say a mask every time you take that mask off. I usually we usually are told to change our masks minimum twice a day. But if you're taking your mask off, breathing a lot of air in while you're eating in an area and in a closed room or something like that, get a new mask. So I know these masks are expensive, but they do change. So that's why you can't put an N95 in your pocket and use it again and then use it again and use it again. You should be using new masks. I know it's expensive. I use a P100 mask at work in a sawmill. So just P100 masks have been mentioned. They haven't gone to the mainstream. So there's a whole body of data on masks that's available. You can look at it. A lot of the I think they're really high quality masks that they're using in sawmills and other areas where there's like noxious gases and things like that are different types of masks. They're not everyday respiratory masks, but I have seen the P100 coming up as a potential for COVID. Is BC making it difficult to get Paxlovid? Well, it's available. The pharmacy, it's kind of been up and down and all over the place. At the moment, you can get it. Your pharmacies can get it. So that's the current status as of today. How do I know if I have COVID when the hospital, health unit, and pharmacies both say that the BC government has decided not to provide them anymore, even for purchase? So I was under the understanding you could still get rapid antigen tests, but the quality's not that good. I could be wrong. And this is what's really difficult, right? How do you know if you have COVID? So I do know that people are getting the rapid antigen tests, and I don't know if they're buying them. I know when I go to my pharmacy, I get rapid antigen tests, but they're older. So how good are they? You're absolutely right. They should be freely available, because it would be, it has implications, an infection. So that's the question to that. How do you access Paxlovid when BC has restrictions on it? So this is an interesting question. And so, yeah, this is an interesting question. I justify that I can write Paxlovid for people with long COVID because they have immune dysregulation. I feel that's pretty valid. So I don't have any problem writing a prescription for it. And I know my colleague, Dr. Arsenault, doesn't have any problems for it. I think the reason that there's the restrictions put in place is from the studies. So they're saying those that are more at risk, diabetes, chronic heart failure, et cetera, immune deficiencies. Well, long COVID is an immune deficiency in my eyes. Their T8 cells are down, their interferons are high, their cortisol is low. So to me, it makes sense, but it is a bit of a problem, for some, I know. So I assume my greatest risk is probably my two kids who are at school, or would their strong immune systems help prevent from bringing COVID home? Well, kids are virus vectors. And yes, they could be bringing it home. Is there what we call herd immunity happening? The tricky part about it is that the SARS-CoV virus kind of mutates every 3 months. So we're dealing with different variants. So I would still say that any respiratory virus your child comes home with, make sure it's not COVID, right? They are your risk, but so is the asymptomatic population. So how common are atypical yet severe presentations of COVID? Without typical respiratory symptoms other than debilitating symptoms such as active fluid illness, neurologic symptoms, tremor, seizure, inner vibration feeling, spontaneous open wound due to herpes reactivation. I'm trying to see if I can summarize this question. So COVID infections can present, like each variant will have a flavor, like there may be more GI symptoms. It's definitely not just a respiratory virus. The virion is found in all places in the body in autopsy studies. So please don't just rely on typical respiratory symptoms as the marker for having COVID. I'm not sure if I'm answering the question properly. The symptoms of neurologic symptoms that you're experiencing, is that due to herpes virus reactivation? So I'm just wondering if you're referring to HH6 reactivation. I'm not sure. Typically, we don't know what HH6 reactivation is because it's actually probably not the full virus that's coming. It's only a part of the virus. So I can't with impunity answer the second part of that question. So a growing number of patients are using nicotine patches to treat long COVID. Could you comment on this and whether it's reasonable? Yeah, so definitely. So nicotine. So let's go back to a simple thing. So I like to try to explain this as simply as possible. You have say a muscle, and you have a nerve with a synapse. So the synapse is the space. And say that the neurotransmitter that goes between the nerve and the muscle is blocked by, say, spike protein or an antibody. What the nicotine does at the N-ACTH receptor is bumps off the invader. So that's the theory. Now, what does it work clinically? This trial had 3 people. Like there's 3 case reports that I could find. So what do I say to individuals? Get the smallest patch, buy a 7, and try it out. Some people will find improvement. The improvement can be in different categories. So if you can't tolerate a 7 patch, get a piece of saran wrap and cut out a wedge and cover the nicotine patch and put it on your skin and see. And then you can just rotate that saran, or get a different saran pie shape if you can't tolerate the higher amount. I don't know how long you're supposed to use them. The studies, it wasn't even a study, it was case reports. So that's the theory, and that's the practice. I don't see any reason why not. How common is POTS with hypertensive tachycardia episodes in COVID? So COVID is associated with about 17% dysautonomia. Now, the hypertensive tachycardia is a controversial topic that I'm still trying to figure out myself. So POTS is about 17% in long COVID. The typical presentation was the study that I sent you. And it's the talked about, it's the lower blood pressure, the higher heart rate. The thing with these studies is they only monitor for a certain period of time. So physiologically, our bodies are trained to, when your blood pressure goes down, to start increasing your heart rate and then squeezing your blood vessels. So I'm not sure yet, because I haven't figured it out with Dr. Raj yet. And we just haven't figured it out. Is hyperadrenergic POTS or the higher blood pressure a portion of long COVID POTS? We don't know yet. Okay. So I would only know, my practice of pattern practice now is, if someone is telling me they're getting spikes in blood pressure, I do an ambulatory blood pressure cuff monitor for $75 through LifeLab, so I can see what's happening, if the lows are coming with the highs, so I know how best to treat you. So it's a bit of a work in progress. Can we get Paxlovid metformin for acute COVID from the clinic before our one-on-one? No, you can't. You have to go to your family doctor. I'm sorry. I just contacted COVID for the 3rd time. If you're a patient in our clinic, just let our secretaries know. We're pretty good on turnaround time. You have to take it within the first 5 days. Okay. Take it with metformin. Will the presentation be available on the METV channel? Yes, it will. Flora Store has been exceptionally helpful for me even before V injury. I'm not sure what V injury is. Recommended by a gastroenterologist and GP. I'm just wondering, I just have to look up Flora Star because it's a trade name. I don't know. 1 second. Oh, it's a probiotic. Yeah, sure. Any probiotic, if that's going to be recommended. It's an all-in-one probiotic. So it's a proprietary name. If your GI specialist and GP are recommending it, I don't, it's got, when I look at the product, itself, it's not, good gracious, they're trying to get me to buy the product. So, Flowstar is a probiotic combination of some sort. It's Saccharomyces, and a couple of other things. Again, we don't know. We don't know which one's right, but give them all a try, because we don't know which ones are grafting. Oh, is is there an this is a fairly specific question. It's an I'm just gonna, because I can't say it, I'll just tell you the trade name. It's a mAb, which is a monoclonal antibody. Um, just a second, I'll give you the Oh, Ampligen. Okay, Ampligen's been around for a while. So Ampligen has been used in the chronic fatigue world for a long time. It's not available in Canada. And I mean, because ME is part of long COVID, it's available in the States. I haven't seen it in Canada. Now, the evidence for it's kind of not 100%. So I don't usually recommend people go to the States to get it. So just that's my feedback on that. Would you be willing to explore doing a BC007 trial for your patient group? BC007. So remember when I talked about in the beginning about the mechanisms and the 6 mechanisms? I think when you're looking at a complex illness that has 6 different mechanisms of potential possibility, there's no one drug that's going to make a difference. So I just want to put that out there to be specific. So this is it works to neutralize autoantibodies in one way. So it's really only working on one mechanism. So I respect that it may be helpful in what you've read, but again, it's not come to trials that we are seeing in Canada. A lot of this is coming from Europe. So no, and we are not set up to do therapeutic trials in our practice. That's much more of an academic lab status. I have LC hyperadrenergic POTS. Was there anything about that at the conference? Again, no. So hyperadrenergic POTS, again, is treated usually with differently, actually. It would be you'd use things, centrally acting agents like clonidine or guanfacine, just like any other, because they haven't identified hyperadrenergic in the information that I have. But when I've looked in a lot of different places, but that doesn't mean I have all the information. So for hyperadrenergic POTS, they didn't talk about it at the conference, and we would treat it as we would any hyperadrenergic POTS. Why doesn't the government acknowledge this illness? So they do. The StatsCan does. Who does an acknowledgement, and I apologize if I said government, it's more the disability companies. And that's a whole talk on itself. The government, and you look at the StatsCan reports, they've been very good about talking about post-COVID. They're using, I think, the post-COVID or long COVID interchangeably. I didn't on purpose put the new StatsCan info up because it was all about disability. It wasn't much different. So every year they put an update available, and it's available, so you can have a look at it. How can we get involved in studies? So studies, specifically looking for brain inflammation without answers, doctors don't take us seriously. So that's why I say look at the long COVID website, because they do have studies and there's a whole section on research there. So I just encourage you to go to that point. The PHSA studies, and Reach BC is another place that you can go to. Citizen science is another opportunity. for patient research. And long COVID web, there's a ton of patient partnered research going on. Visual difficulties at the conference. No, not specifically. Visual difficulties are known about, but it wasn't actually specifically discussed. IVIG. What is IVIG? Intravenous immunoglobulin. Okay, it's plasma. It's a concentrated immunoglobulin product available through the blood bank, and so it's a bloodborne product, and it's just a whole bunch of IVIG, intravenous immunoglobulin. So just a small immunoglobulin story. Immunoglobulins are produced by B cells, part of our immune system, and they come in, there's different types, like there's A, G, M, G. So the IgG is the product that you have in IVIG. Okay. How can we try IVIG? Some people in the States are on it. Would an immunologist trial it? No. Because it's expensive. Well, there's lots of reasons, but the short answer is maybe it's happening in the States off-label, but it's pretty impossible to do that in Canada. So I'm sorry. Is it recommended to have flu and vaccine booster? So I do personally. The flu shot is usually recommended for vulnerable populations and those over 65, and vaccine. I always say separate them. They're both, so the flu vaccine is live attenuated, can make you a little bit sick. Some people have really significant reactions to COVID boosters. Don't know if you're one of them, but I usually say separate them out. IVIG made me flare hugely, huge flare of severe extreme eczema, diagnosed by allergist immunologist at the 5-month mark. So I'm not sure how to answer that question. Your reaction to IVIG may have been different than the experience that has been seen elsewhere. Are there any updates on the clinical trials occurring in Canada? So please go to the, like I couldn't do every trial. So the long COVID website lists all the trials that are going on right now. There's multiple in the works. I picked the ones that were highlighted at the conference, but there's a lot, and it would take me hours to go through all of them. So the long COVID web is a very good resource for that. Help the insurance understand. Well, we try. Thank you for the kudos. Is research from SARS-CoV-1 useful or relevant? Well, that's a really good question. It's a really good question. The SARS-CoV-1 was a totally different ball of wax. I think it sort of laid the stage about the importance of some aspects of this virus, but SARS-CoV-1 killed most of its hosts. So there wasn't a whole lot of time to do research on SARS-CoV-1. I'm just being honest. So SARS-CoV-2, we're learning some from the SARS-CoV-1 work, but remember 50% death rate. So not a lot of opportunity to do a whole bunch of research. Underlying chronic Lyme disease. So chronic Lyme disease is a whole topic in itself. I'm going to just pass on that one because we're almost out of time. Can we access the conference material? I think you had to be a participant. We do have something, I don't know post after if you can or not. I do, you'd have to ask the long COVID web master to see about that. Why metformin in acute infection? Well, there's a bunch of studies talking about it. And if you go to the PCC guidelines. They'll go through it in plain language. There's a section on metformin and use in acute illness. Can you repeat the 6 mechanisms? So they're in the slide deck again. It's viral persistence, immune dysregulation, gut dysbiosis, neurocognitive, and this is where my own brain falls apart. So I'd have to go back to the slide. Just give me 2 secs here. Sorry, everyone. I know this is hard to watch.
Jane, while
Yeah.
you're doing that, I'm gonna put a plug in for a website called donatemask.ca.
Great
And
idea. Yeah.
donatemask.ca, I buy my masks there because anybody who can't afford a mask gets them free. And for the people of us who can afford it, the money that another company would make as profit would go towards getting masks for people who can't afford it. So donatemask.ca. And the other thing about that website is in their store, if you're having a hard time finding the test kits, they actually sell the test kits as well.
Fantastic. Thanks, Rick. So here's the 6 mechanisms, the ones I couldn't remember at the end there. I'll just leave. What is phenotyping? Phenotyping is like, so it's grouping like people alike. So an example is all people with red hair. That's phenotyping. Or all people that have Ehlers-Danlos syndrome. It's putting groups together to try to study like people. So that's what phenotyping means. But in a different, there's different mechanisms with phenotyping that are used. Okay. So, but that's the concept behind it. Oops, sorry. I'm just going to exit those slides. Sorry about that. I thought I was exiting. Sorry about that. I was trying to exit. Sorry about this, guys. The couple last questions while we have a moment here. Any research on long COVID impacting PCOS or PMS or the reproductive system? Yes, there is. Is post-viral depression? Yes, it is a recognized condition. The virus causes, the second bucket of long COVID that we talk about is psychiatric. Lots of it, okay? On Paxlovid, most of my long COVID symptoms disappeared. Can you get a longer course? At the moment, the studies are saying that it's not. So I'm personally not prescribing that. If you have severe ME/CFS, should you try to get vaccinated? Even when your health got very bad after being vaccinated? I guess it really depends on how, I always am going to say yes, but I do recognize the difficulties. Now, sometimes you can actually see if you can pay for someone to come into the house. Now, the question is, do you ever leave your house? Are you always isolated? I mean, the answer is we recommend vaccination, but we understand when you have severe ME/CFS, what an impact it does have. Can you explain the gut microbiome and brain connection? Well, essentially the leaking stuff from the gut goes up to the brain and activates the brain inflammatory cycle. That's about the simplest way I can explain it. It's a little bit more complicated, but that's the simple explanation. Is there evidence for iota carrageenan nasal spray? I use it as part of my Swiss cheese method, but wonder how effective it is. I actually would have to pass on that one because I don't know about that particular product. I know what you mean by the Swiss cheese method for protection, but I'm not sure about that one. I'm wondering if you have any comments about mycotoxins contributing to long COVID or ME/CFS. Can't really comment on that one. Can you talk more about visual changes and treatment? So a lot of it may be vestibular dysfunction. So often what I usually recommend if you're having visual changes, first get your eyes checked. And then the second thing is visual retraining if you can do it. Is there a suggested approach to treating mitochondrial dysfunction? Yes. The mitochondrial dysfunction is usually recommended multiple different products that we utilize. And also Mitomatrix, I'm just thinking of a couple off the top of my head. And then do you have any clinical experience with taurine supplementation? No, not really. I just say buy taurine and take it at the label 500 to 300, 3,000. I don't, taurine's probably salted. It's an amino acid, so it may be with a chloride of some sort of thing. But when I look, there's all kinds of products available. I don't know which one's better than the other. And I think we're coming to the end here. So I did my best, everyone. And thank you so much for coming. And we're going to do this again December 17th, I think.
Yeah. And then once Dr. McKay updates the slides, we'll get those to you.
All right, everyone. Have a wonderful evening. Thanks, everyone.
Thanks, Dr. McKay. Take care.
Bye-bye.